Med Journal Club. In the next few minutes, you'll learn what makes or breaks the hottest malaria trial of the year and how its results might shape your clinical decisions. Today, we're dissecting the BOHEMIA trial, just published in the New England Journal of Medicine. If you're a clinician or a passionate medical student wanting evidence-based insights, you're in the right place. Let's begin with some context. Malaria remains a formidable global health challenge, causing 249 million infections and more than 600,000 deaths just last year, most tragically in children from sub-Saharan Africa. Current frontline tools, long-lasting insecticide-treated nets and indoor residual spraying, have saved millions, but their effectiveness is under threat. Mosquitoes are evolving, becoming resistant to standard insecticides, and changing their biting behaviors to avoid them. This is the critical backdrop that makes research into complementary vector control strategies, like mass drug administration with ivermectin, so urgent. Ivermectin is a broad-spectrum antiparasitic widely used in mass drug administration against neglected tropical diseases. When humans take ivermectin, mosquitoes that feed on them are likely to die, thus disrupting malaria transmission. Adverse effects are typically mild, think fatigue or dizziness, but its safety profile is well established. Albendazole, in contrast, is a deworming agent, commonly used but does not impact mosquito vectors or malaria transmission. In the BOHEMIA trial, albendazole provides a fair active control arm to tease out ivermectin's unique mosquitocidal benefits. The BOHEMIA trial set out to answer the question, does mass administration of ivermectin reduce malaria transmission in high endemic regions? The hypothesis is that monthly dosing of ivermectin for 3 months would lead to at least a 20% reduction in malaria incidence versus albendazole in children. Let's break down the methodology. This was a cluster-randomized, open-label, assessor-blinded controlled trial conducted in Kwale County, coastal Kenya, a region of perennial malaria transmission and robust bed net usage. A total of 84 clusters, household-based geographic units, were randomized equally to either ivermectin or albendazole arms. The study population included over 28,900 participants for safety monitoring and nearly 1,900 children aged 5 to 15 in the efficacy cohort, followed monthly for 6 months after 3 rounds of drug administration. Ivermectin was dosed by body weight, while albendazole was given as a standard 400 milligrams tablet. All doses were administered under direct observation. The median age of participants was 25, gender split was roughly equal, and about a third of households were in the lowest wealth index. Treatment coverage was 66% in the ivermectin clusters and 74% in the albendazole group. High bed net usage was confirmed in both arms at about 80%. The co-primary outcomes were cumulative malaria incidence in children and incidence of adverse events in all treated participants. Let's get to the results. And here's where it gets interesting. Children in the ivermectin group experienced 2.20 infections per child year at risk versus 2.66 in the albendazole group. That's a 26% reduction in malaria incidence. Statistically, the adjusted incidence rate ratio came in at 0.74 with a 95% confidence interval of 0.58 to 0.95 and a p-value of 0.02. Meeting WHO's minimum efficacy target for new vector control tools. Simply put, this is the first large-scale field trial to confirm a meaningful real-world reduction in malaria incidence using ivermectin. What about safety? Across more than 56,000 individual treatments, there was no significant difference in serious adverse events. The incidence rate ratio was 0.63, but confidence intervals crossed 1. This means that ivermectin didn't raise red flags for severe harm. Overall adverse events were about 65% higher in the ivermectin group, but the vast majority were mild and transient systemic, sensory, or neurologic symptoms. This side effect profile aligns with what we've seen in decades of ivermectin use in mass drug administration for other parasitic diseases. Now let's talk about the strengths of this trial. First, this was a rigorous and well-powered cluster randomized trial with a large representative population and WHO oversight, giving us high confidence in the findings. Second, the trial achieved comprehensive safety monitoring. Over 56,000 treatments were tracked, and there were virtually 0 serious drug-related adverse events, not just an academic point, but crucial for real-world scaling. Third, the statistical robustness, multiple sensitivity analyses, real-world settings with high bednet coverage, and adjustment for a wide range of confounders. Importantly, the results remained consistent across these analyses. As always, no study is perfect. A key limitation was that this was an open-label design. Participants knew which drug they received, potentially introducing behavioral bias. Differential coverage between arms could also have skewed results. The study also had to contend with confounders, like frequent use of artemether-lumefantrine and a lack of baseline malaria incidence data, making risk estimation less precise. And, crucially, the generalizability is limited as the setting, a single Kenyan county, may not represent all malaria endemic areas worldwide, especially those with different transmission patterns or levels of health infrastructure. What does this mean for clinical practice and public health? For the first time, we have solid evidence supporting the use of mass ivermectin administration as a complementary tool in malaria vector control, meeting the WHO's target product profile of at least 20% reduction in incidence. This could help break the stall in malaria progress driven by resistant mosquitoes and evolving vectors. But for those eager to advocate broad adoption, remember, successful integration will require further implementation research, especially in under 15 kilograms children, pregnant women, and other settings. It also means collaborating across programs, since mass ivermectin delivery could be coupled with ongoing deworming or neglected disease campaigns for efficiency. So, to wrap up, monthly ivermectin reduced malaria incidence by 26% with no excess in serious adverse events. It's a promising, safe, and scalable strategy to complement existing control tools in high transmission settings. To end things off, I want to leave you two questions as a food for thought. How could ivermectin be integrated into your clinical or public health context? What gaps remain, especially for vulnerable populations or in different geographic regions? Drop your thoughts and questions in the comments below. If you found this analysis valuable, don't forget to like, subscribe, and turn on notifications for more evidence-based critiques. Your engagement helps us reach more medical minds worldwide.